Good afternoon, friends. Myself, Dr. Gururaj Sangondimath. At the outset, I would like to thank Bombay Spine Society for giving me this opportunity to talk on selection of fusion levels in AIS in lenke type 1 curves. Basically, why this is controversial? Because if you see in this paper, all of them are senior surgeons. Still, they ended up choosing 5 different proximal levels and 4 different distal levels for fusion of these curves. So that is why we are discussing about this today. So clinically, if you want to select fusion levels, you should always look at these 4 parameters, that are shoulder balance, truncal shift, thoracic prominence, and lumbar prominence. And we should also always remember this important classification of AIS, that is lenke classification. So considering general principles of fusion levels when it comes to AIS is, in the sagittal plane, we should include all pathological curves. Never should we leave out kyphotic curves, and we shouldn't stop in between the pathological curves, be it in the coronal plane or be it in the sagittal plane. And in transverse plane, in selecting LIV, we should always go to a rotationally neutral vertebra. And the disc that opens on both directions in bending films can be left outside the fusion level. So LIV should always be within the stable zone or within the zone which is bisected by the CSVL, that is central sacral vertical line. In immature patients, LIV should derotate to neutral or near neutral on bending films. And always secure your lower instrumented vertebra with the secure fixation with pedicle screws. Anterior fusion applies to only lenke type 1 or 5 curves, and it is done when you want to do a single curve fusion. And in this, you fuse from end vertebra to end vertebra. You can use a single rod technique or a dual rod technique, depending upon your training. The more controversy exists when we come to this entity called selective thoracic fusion, which was described by Moe in 1950. What is selective thoracic fusion? When a fusion you do of a thoracic curve in the presence of a lumbar curve. So that is called selective thoracic fusion. This is based on the principle that the leftover lumbar curve spontaneously corrects itself with time. And the selective thoracic fusion should give a long-lasting correction of all components of the deformity and also aims at maintaining as much as cranial and caudal motion segments as possible intact. So what are the main 2 causes of basically distal adding on or a basically curve progression of the lumbar curve? That is inappropriate lower instrumented vertebra selection and skeletal immaturity. That's why in a skeletally immatured children, we have to be very, very cautious when we try to do a selective thoracic fusion. In this paper, Wong et al., they said that if LIV and CSVL distance increases in the postoperative period by 10 millimeters, it is a predictor of distal adding on. They also said how to choose a LIV in lenke type 1 curves. That is, a LIV should be the first vertebra from the sacrum, that is away from CSVL more than 10 millimeters. They also said that if a preoperative standing radiograph, if LIV plus 1 deviation from the CSVL is more than 10 millimeters, then it is more likely that you will have a adding on. Again, there is a concept of 1 AR and 1 AL curves depending upon the tilt of the L4. 1 AR curves are the long thoracic curves and 1 AL curves are the short thoracic curves. 1 AR curves, you have to go more distally into the curve for the fusion. And it is also said that 1 AR curves have 2.2 times more likely probability of adding on. So that is why if you see these 2 curves, we have fused short here and we have fused long in 1 AR curve. Suk et al. Also said that when preoperative neutral vertebra and end vertebra show no more than 2 level gap difference, the curve should be fused down to neutral vertebra. But if the gap is more than 2 levels, we should fuse neutral vertebra minus 1. That is, we are saving levels there. This is again an case example. For the want of the time, I'll just them. Coming to 1 curve, that is 1A and 1B curve should be subject to selective thoracic fusion, and they're amenable in 90% of the times for selective thoracic fusion. What is the difference? In a LIV, in a 1A curve, you go to a last vertebra touched by the CSVL. But in type 1B, you go to the most cephaloid vertebra intersected by the CSVL. That is last substantially touched vertebra. That's again an example of 1B curve. Exceptions for selective thoracic fusion are obesity, if the curve is more than 80 degrees, and if you have a junctional kyphosis, you have to be careful in doing selective thoracic fusion. Coming to main thoracic curves, that is type 1C curves, most of them you might have to go down and fuse the lumbar curve also. But in some, you can do a selective thoracic fusion. What are the criteria? So the ratio between the Cobb angle measurements of the thoracic and lumbar curve and apical vertebral rotation and apical vertebral translation of the thoracic and lumbar curve, if all these measurements are 1.2 times more than the lumbar curve, and if there is no thoracolumbar junctional kyphosis, you can still do a selective thoracic fusion. But here you have to be careful. You have to leave some angulation at the lower instrumented vertebra to accommodate the lumbar curve. So that's an example of, again, 1C, where this 1.2 criteria didn't satisfy. We went ahead and did a long fusion. Coming to the upper instrumented vertebra in lenke type 1 curves, you have to see for the shoulder balance. If the in right curve, right shoulder is high, you can go safely go to D4 or D5. If the shoulders are level, you have to go to D3. If left shoulder is higher as compared to right shoulder in a right thoracic curve, you have to go to D2. So, in nutshell, most of the lenke type 1A, 1B curves are amenable for selective thoracic fusion. If LIV is chosen properly, you can prevent distal adding-ons. In lenke type 1C curve is also amenable for selective thoracic fusion, satisfying the criteria of 1.2 ratio. And this selective thoracic fusion, we should remember, is based on the principle that lumbar curve corrects itself. If it fails, then your selective thoracic fusion will fail. Thank you.